Next up, we have Samir Gupta, who has served as the Vice President of Medical Affairs at the University of Minnesota Medical Center since 2019. And in this role, he is primarily responsible for quality and safety across the Chief Medical Center, patient flow, medical staff oversight. Prior to his current role, Dr. Gupta was the Chief Medical Officer at Masonic Children's Hospital and held a number of other operational leadership roles at that children's hospital. Samir also previously served on the Board of Directors for University of Minnesota Physicians. Dr. Gupta is a pediatric intensive care physician by clinical background and is an associate professor in the Department of Pediatrics at the University of Minnesota Medical School. His previous research was primarily centered on clinical quality improvement in pediatrics. And Samir received his MD from the University of Maryland School of Medicine and completed his pediatric residency and pediatric critical care fellowship at Rainbow Babies and Children's Hospital in Cleveland. He received his bachelor's degree in biomedical engineering from Case Western Reserve University and completed his MBA from the Carlson School of Business at the University of Minnesota. Everyone welcome Samir Gupta.
Here we go. Yeah, I didn't turn it on. That would be helpful. Good afternoon, although I think it's actually good evening now. So thank you for having me here. Really appreciate the opportunity to have this conversation with you. I really appreciate that Mark opened this up talking about Great Clips, because I also go to Great Clips. I don't like to admit that. I don't know why. I mean, it's a fine institution. And it's interesting because part of what we've been talking about and what I like to call the easy button is the easy button, right? So whether it's Virtuell, whether it's the apps that we're using, like how can we access healthcare in an easier, better way? And for me, that's Great Clips. I don't have to make an appointment. I don't have to check my calendar. I happen to have some free time. I go on the website. I'm sure they have an app too, but I just go to the website and find the location that has the time frame that works for me, and that's where I go. And they have my stuff on file. They can look it up and say, oh, that's the haircut you got last time. I'm like, this is perfect. It's exactly what you want. But I think that's what we want out of our healthcare. We want it to be as easy as possible. And so anything we can do to make it easy for our patients is going to also be then effective, and then one, receiving the healthcare that they need, and then more importantly, be healthy, right? And sometimes we forget about the actually having health, and because we focus so much on the actual health care that we deliver on an everyday basis. And so as mentioned, I work at the University of Minnesota Medical Center. I'm the Vice President of Medical Affairs. I am kind of the farthest thing from what we've talked about so far. Operationally, I'm an inpatient kind of operator and manager. Clinically, I work in the ICU and talk about the most inpatient space you can be. And so very, very different than what we've talked through before. Yet what I'm going to talk about today is actually outpatient, which is surprising coming from an ICU doctor who works at a quaternary care medical center. But let me tell you a little bit about University of Minnesota Medical Center, and actually it gives you the story about how we got to the story I'm going to tell about this project we did. So the medical center is a 900-bed quaternary care academic medical center. What does that mean? It means we pretty much can do anything that we need to do for a patient, from kind of regular inpatient hospital care all the way to the most technologically advanced treatments out there. Through that process, we also provide what we hope is great clinical care to our patients that's friendly. And I think we also heard about access. We'd love it to be accessible. It's not. And for a lot of reasons, and I'll explain that a little bit more in a little bit. We also are a major research institution, and so we're always trying to drive the next generation of cures and treatments. And I'll tell you what, there's a lot more cures coming out than there are even treatments, and every day we're seeing more and more out there in terms of cures, and that's really exciting. It also puts a little more pressure on the work we do every day. And Mark mentioned the people that we train. And so University of Minnesota Medical Center and the medical school are a hub of training for the next generation of healthcare professionals. So whether it be pharmacists, nutritionists, nurses, physicians, CRNAs, all sorts of individuals. And we like to quote the stat that 70% of the physicians in the state went through either the medical school or the University of Minnesota Medical Center. 70%. So we are the reason that we are what supplies the state, at least with their providers and physicians. So things have changed a lot for us over the last few years. And, I took my role for the medical center in 2019, about 3 months before the pandemic started. So it was like, it was trial by fire. It's like, here you go, take on this role, you're managing this medical center. Oh, by the way, things will be very different after you started. And things really are different for us at the medical center. And some of this is probably evolution of healthcare anyways, that was, hastened by the pandemic. Some of this is just things that are post-pandemic realities for us. And some of it's local to the state and some of it's seen nationally as well. What we've seen is our volumes have gone up tremendously. And so probably by about 20% from the pre-pandemic time period. And initially we had the drop in our census with COVID, staffing constraints, but now that we've staffed up and we have all the resources we need to take care of patients, we're still full all the time. I get calls from regions, hey, can you take this patient? I'd love to. Can you give me a couple days? That's our normal response. So our volume's higher, our acuity is about 25% higher. So you look at 2019 data to 2024 data, our acuity has gone up by 25% in most ways that you can measure it. Again, I think some of that is part of healthcare in terms of moving more and more stuff outpatient, so what ends up in the inpatient space is higher acuity. It also speaks to what we're trying to do at our medical center, which is, we really are built to take care of the highest acuity and most complex patients, so that's what we should probably do. And so what we're doing is we're taking the patients that don't need to come to us and sending them to other places, and luckily we're part of a healthcare system, and so we can take other patients and send them to lower acuity centers. And so that means our acuity keeps going up. The demand of our services keeps going up as well, and I think there's a lot of reasons for that. But one of the primary ones is that healthcare across the state and across the country is changing. So centers that used to be able to say, I'm going to have oncology at my hospital. I'm going to have an oncologist. I'm going to actually deliver chemotherapy. They decide, that costs a lot. The infrastructure to do that is very, very expensive. I can't hire the docs, right? We talked about the shortage of providers. Because I can't hire 2 oncologists or 2 surgeons who want to take call every other week, 365 days a year. They want to have 5 surgeons in their group or 5 oncologists take call once a month, right? And be able to actually have a little bit of a work-life balance as they see it. And so other hospitals, smaller hospitals, can't actually staff those resources to take care of those more complex patients. And so more and more of those patients are coming into tertiary, quaternary care centers. They're not being taken care of in the community anymore. They're coming into places like Regions, Allina, University of Minnesota Medical Center to be able to receive that kind of care. So the demand has really increased. And our capabilities keep increasing. We keep developing more technology. One of the big things that's coming down our pipe, or it's already here, is gene therapy is revolutionizing the way that we're going to take care of patients. And some of these things are handled on the outpatient side, which is fantastic. They don't need to come into the hospital. Again, I'm a hospital person. But some of these gene therapies require hospitalization. And when we start talking about things like treatments for sickle cell and thalassemia, there's lots of patients. And there is not that much capacity. And they're going to need inpatient care. And so how are we going to deliver that? How are we going to decide who gets it first? There's lots of these things. So we're sitting here as a medical center with a huge shift in our landscape in a very short period of time, and we're trying to catch up. And so we've done the normal things. Let's decrease our length of stay. Let's move patients, I said, to lower acuity spaces. Let's make sure we're leveraging, our post-acute care, our home care, all those different resources that are out there. And all those resources have taken a little bit of a hit over the last few years as well, post-pandemic. But we're doing all those things, and it's getting us where we want to go, but probably not nearly enough. The other piece is on the other side of this chart here, which is it's harder to get patients home. Their social support's really changed out there in the community. One, we're seeing a lot more mental health, and whether we're detecting it more or it's actually greater prevalence, it's hard to always know that. But we know our resources for mental health are definitely down. The opioid crisis has been a big part of this. People's financial health is also taking a big hit as we start to see that finance gap continue to grow. And what we saw post-pandemic is, you used to have your sister, your brother, your mom, your daughter would say, oh, you know what, I'll take you in, I'll help you out, I'll come out the house 3 times a day, or I'll do all these things. That's not happening anymore because those people have their own stressors that they're working through, and so that social support has really gone away for some of these patients. So I said, I'm an inpatient doctor, but realizing as we're working and I'm trying to manage the capacity of a hospital, saying, well, how can we do this differently? This is gonna be completely different than what we've heard about already, which was kind of population health type of looks, using a lot of technology. Where this is a throwback, it's old school. We said, you know what, there's all these patients that come into our hospital on a regular basis, right? They have significant chronic illness, they have significant needs, and you know what, they don't know how to access healthcare in a reasonable way, or their health is so poor, they have to come into the hospital constantly, kind of get tuned up. So we did an assessment, and we said, you know what, there's about 100 of these patients, and these 100 patients make up for something, I can't remember, it was like 2,000 patient days. At our hospitals over the course of like 6 months, a huge number. Well, what can we do differently for them? So we said, we're gonna take 10 of these patients and we're gonna just try something. We're gonna actually, give them a hug. We call them our high utilizer group, hug. And what this is really highly coordinated care for a small group of patients in a multidisciplinary fashion. And it's really just complex care planning. It's nothing innovative. It's super old school, but doing it in a little bit different way. And the whole idea is, can we get these patients to use the ED last, come into the hospital last, right? And again, these are their highest. So we picked our 10 highest utilizers. These are individuals who are in all the time, like 4 or 5 ED visits a month, in the hospital once to twice a month, regular basis. Do a deep dive into who they are, their psychosocial needs, the support that they have, their medical diagnosis. And we actually have a group that is consisted of a psychiatrist leader, a pain physician leader, a primary care physician leader. These are all people who are clinically active as well as leaders in their space, a care management person, and then we have an administrator that helps to kind of run this program. It's a lot of resources for 10 patients, right? A lot of resources. And the idea is that we develop care plans and really do high touch services to try to keep these patients out of the hospital. And so I'm gonna quickly go to results because I'm getting time flags here. And so, so what we found is when we did this, so we started this in October 2022, so it's been about 2 years, started with 10 patients, and then we actually got a grant, because we had some good success, got a grant, took on another 10 patients, and then just this June, we put in a third cohort of what we call our pain cohort. These are individuals who have significant pain diagnoses, that with that, some opioid use disorder as well with that. A lot of times your chronic conditions oftentimes have some chronic pain associated with them, and often that's been usually controlled with opioids, and then that develops its own set of problems as well. So what we saw with our first group is our admits went down by 55%, and the second group went down by 51%. The days per month also went down equivalently, as you'd expect, fewer admissions, fewer inpatient days. We saw an initial increase in our ED visits right off the bat, and that's because I think they started to recognize when they weren't doing well and actually seeking care earlier. And so to see they come into the ED, but they wouldn't need to be admitted. Big difference, right? So an ED visit is expensive, an inpatient hospital stay, much more expensive, right? And they don't get to be home, right? One of the key pieces of this is we're now taking patients and saying, you know what, you can be healthy at home versus getting health care in the hospital. And we saw our PCP visits, obviously, primary care physician visits go up significantly as well. The pain group, again, this just started in June of this year. So MMEs is the morphine milligram equivalents. It's how we kind of look at opioid use in a standardized fashion. So you take fentanyl or Dilaudid or oxycodone, like what does that mean in terms of morphine? So that way it standardizes it so we can be all talking the same language. You can see there's a group of patients, huge MMEs. These are big, big numbers. So just give you some context. It's been 4 months. Huge, dramatic decreases. Why? We're touching base with these patients regularly. We're looking at their care plan in a very, very holistic manner. We have experts in those fields assessing these patients, creating those care plans, and then making sure they get implemented, right? We're not leaving it up to chance. We're not saying, hey, call this person, call this clinic. We're getting them rides, we're picking them up, we're reminding them. We're doing all those pieces. The good thing is it gets results. The bad thing, it's a lot of resources for about 30 to 40 patients that we've taken care of the last couple of years. Now, granted, they've really reduced their inpatient visits. They are healthier, right? They are doing better. These are patients that we have changed their lives. They're not in the hospital like 40, 50, 70 days a year, 100 days a year, 200 days a year. They're spending most of their time at home now. So what did we learn? We started this program, and within about 9 months, we had physicians calling us from all over, saying, hey, I want to get my patient in. I have a patient that could really use these services. And we said, that's great. Our goal is to be high touch as much as possible. And so what we did is we actually ended up creating a consult service. And so we said, great, you have a patient. It doesn't really meet our definition of high utilizer because you haven't had this many visits and all these kind of other aspects. But we're going to do a complete consult for you, looking at the mental health, the social support, all those pieces, any kind of, medical needs. We'd bring in specialists, rheumatologists, neurologists, whatever else, and create a comprehensive plan for them and say, here you go. This is what we believe you need to do. Share this with your team, your clinic care coordinator, whoever else you need to do, and this is what we think will help your patient achieve health. And then we created these care plans as well, because some people didn't have those resources, some physicians, and so we'd create the care plan for them and actually stick those care plans in Epic. Because sometimes these patients oftentimes don't seek care at one ED or one health system. And so these patients would go to Health Partners, they go to Allina, they go to MHealth Fairview, they go to 3 different hospitals to seek their care, and oftentimes, and none of it's coordinated. The good thing is we're all Epic shops, and so you can stick this in a little tab in Epic, and you have this great care plan that pops up. Patient comes in, care plan says this patient has a care plan, and it tells you exactly like, hey, this is what works for them, this is what doesn't work, this is why you should admit them, this is when you shouldn't admit them, this is who you should call for their follow-up care to arrange that. So it creates this really nice kind of recipe for these super complex patients, right? You're an ED doc, you're trying to churn through patients. It's really hard to then take a look at this really complex patient, and the easy button for them, right, the easy button, let's just admit this patient. I don't know if I can send them home. I don't know what to do with them. I'm just gonna admit, and the hospitals will take care of it, and they'll dig in deep over the next 2, 3, 4 days and finally get this patient out. Instead of saying, you know what, this patient doesn't meet these criteria, I can call this care coordinator, I can get them out. The lessons we learned, man, that multidisciplinary aspect of this is really big, right? It's not just a care coordinator, it's not just a social worker, it's getting that physician engagement, the expertise, and then being willing to, again, give the high touch services. The other part we really learned was on the inpatient side, we oftentimes have care conferences. You have the super complex patients, you bring together the neurologist and the hospitalist and maybe the dermatologist, whoever you need to talk about that patient. It doesn't happen very much on the outpatient side, we figured out. So we actually created those opportunities to have those care conferences between the subspecialist and the primary care physician for those patients. It's amazing, get them into the same virtual room, and they're talking now about one patient and actually communicating versus like, I put this note in the chart, I put this note in the chart, and we should never actually have a full conversation together with all the individuals. And so that piece was a huge learning for us. Like that's the first thing we tell people when we create an ad hoc one is get the people together and have a conversation. And then engaging social supports. I said that a lot of those family members weren't really helping anymore. Guess what? If you talk to them, they want to help. They want to be there. And so sometimes it's just re-engaging. A lot of times that patient doesn't feel comfortable reaching out to their family members to help them out. And so oftentimes we would make that connection for them and would make all the difference. So how do you scale this, right? I can't create this over and over and over again because it's just too costly and we need to impact more patients. So the 40, 50 patients that we've taken care of fully ourselves probably impacted another 50 or 60 through our ad hoc care plans and consults. But we need to do more. And this is now we get to technology, right? Like there's gotta be a different way to do this. One, primary care engagement. We need to get patients into their primary care physicians, however that is. A lot of these individuals may not have the ability to access the virtual technology to be able to do it really easily from their homes. Some of them might be able to. How do we get them those resources, that technology to do it so we can check in regularly? How can we start detecting these patients before they become high utilizers? Right? So what's our process to be able to say, you know what, this patient's heading in the wrong direction, and before their health gets so bad that they do have to come inpatient and they do have to get tuned up regularly, how can we figure out this patient's heading in the wrong direction and intervene differently with a lower resource, kind of application? for these patients. That's all I have to say, my little story.
Thanks so much. I'm deeply interested in the work as a physician and as somebody who pays for healthcare, so thank you. But my question is scalability, and I'm especially intrigued by the consult model because that feels where the scalability is. Are you able to study the impact of that consult model and this creation of a care plan in Epic to understand the impact?
Yeah, so we actually, every patient we touch, we follow. So we do have that data. I didn't present it all here. And so, yeah, we see anyone we create a care plan, those Epic care plans that we put out there, we see significant drops in their inpatient admissions. Not their ED visits, right? Because that's where the care plan gets access, is in the ED, unfortunately. So we do see that. We are following all these patients that we're touching. The scalability piece is huge. What I've told my team is we need to, 2025, the goal is to impact 1,000 patients. So let's think about how we impact 1,000 patients, understanding the lessons learned that we have. So the consult model is one, the earlier detection. So we call it the rising hug patients, right? Who's getting there and how do we know that they're gonna get there, and then be able to understand what are the low resource kind of tools we can utilize to impact them right now. Knowing no idea of whether it'll work, right? It may be that some of these patients really need just high touch services to get them on the right path. But we graduate patients, right? So we have graduation, oh, you have graduated from us, you are better, you know how to access your healthcare, you have a support system, you all these things, great. See ya, we had another patient in.
Are you looking at different talent to, especially for those sort of rising hugs or those moving towards the hugs, different talent versus clinicians or clinically trained people to sort of get upstream and lower the cost of the program?
Yeah, well, I think, one of the things we can utilize as APPs is what we've talked about and say, great, we don't necessarily need, specific expertise because, we don't have a neurologist, we don't have a rheumatologist. What we need is someone who can, quarterback the team, right? And so, yeah, we've thought about maybe the next iteration of this is that piece. What's really interesting, that mental health aspect is so big, right? You talked about engagement with the app and, managing health is all about, or as a provider of healthcare, it's about managing behavior so much of the time, and behavior modification has been a huge part of the success rate in a lot of these patients, is sending them to behavior modification. And that's been and I didn't put that as a lesson learned, but it's been a big lesson learned for us, is getting those people in there. And there are resources in our community. It's just hard to access, and the general population has no idea. They don't know what they need and how to get it.
Thank you.
We'll create a support group.
So healthcare accounting is complicated and opaque. I'm curious, did anyone try and figure out how much more it costs or how much
Oh, you're being north of $1,000. So, it's. I won't go too deep into this, because this is my constant argument with our CFO. Is how if I save a bed day, what's that worth? And so we finally agreed on something. It's worth about 20% of a bed day, is what we agreed on. And the only reason why we can say this is because, if I didn't have a wait list of 40 patients, which I typically do, 20 of them in the ED and 20 of them sitting outside in other hospitals, right? We talked about regions and other places like the VA. I have a constant supply. There's no shortage, so I can always fill the bed. So it's not that. It's what I fill the bed with. And now we're talking about how much margin am I creating off a patient? And this, again, we just had a very nice discussion about creating health, and now I'm talking about creating money, which is very different, but it's our reality. And so what I say is, at least at our medical center, I could fill in that patient with a cardiac surgery patient or an oncology patient or a transplant or something of that nature, which is a high margin type of diagnosis, versus a patient who, will come in for a couple days, low margin diagnosis. So we decide on 20% is what we decided on. So that's how we do it. So every time we come up with one of these plans, so we actually, another thing that we did about 2 years ago is we actually own 10 shelter beds at a homeless shelter. And we use those 10 beds to take patients who are unhoused, who still need to continue their medical care, but would normally do it at home. And we actually just send them there. We have a nurse that staffs that 5 days a week. We have mental health that goes there. And those patients then can be in that space. And so it costs us money. It costs us about, $750,000 a year to pay for those beds. But it's worth it on the back end because I free up 7 to 10 beds every day that those patients will otherwise be in, that I can fill in with other patients. And I can talk through, we're a resource for the state. Every year we take care of patients from all 87 counties in the state. If I don't have beds, it's a problem, right? I need to maintain beds. So we find this as a way to make sure that we can grant access to patients who need it. And so anything we can do, but that's how we deal with the financial piece. As I said, it's worth about 20% is what we decided. That's what the CFO and I landed on.
Hi, Samir. Quick one. The 5 specialties that were chosen, was it based on some research? The primary care, the pain leader, the admin, care coordinator, and one more.
So primary care, it's fundamental, right? Like you have to have a primary care physician. It's the person who's going to make sure that you are, is managing your healthcare. It has to be the person who manages your healthcare. And so that one's easy. The pain piece, so many of these chronic conditions, the pain aspect is so big. A lot of these patients coming in with pain, needing more pain meds. And so it became very clear that we needed that expertise. And actually, we didn't start with the pain medicine physician on our team. We brought that that pain medicine physician wanted to be on our team because he saw the impact of what we're doing and said, you know what, this is huge. Because he was seeing less of his patients in the hospital and more on the outpatient side after we got started. And he's like, I want to help out. I want to do this. So we don't actually pay for any of the physicians' time. These are all people who are donating their time because they actually find so much value. The psychiatrist we have, he tells me it's his best hour of the week, right? That he just gets to sit there and really talk about patients, dive deep, and do what, kind of doctors want to do. Take care of patients and do it in a meaningful way. So that's the mental health piece was, very much tied. A lot of these patients with chronic illnesses have depression, anxiety. They oftentimes have behavioral disorders that, prevent them from actually taking care of themselves. And so that was an easy add and very, very helpful.
Thank you so much. And